Good afternoon. I'm Pedro Ibarra. I'm filling in for Faye Evans, who is not able to be here with us. We are presenting the panel from the WFSA. This panel includes some activities of the role of anesthesiologists outside the OR. And so in order to understand what the interest of anesthesiologists have in these activities, we at the WFSA generated a survey among our members, and we had some responses for that. We had 133 responses from different countries around the world. And when we asked about where people performed procedures outside the OR, about 70% did anesthesia or sedations outside the OR. 60% participated in the multidisciplinary discussions. 60% provided education for other specialties, which was quite interesting. And 60% work in pre-op assessment clinics. So it's interesting that there was a major interest in activities outside the regular OR activity among these surveyed individuals. And asking about whether anesthesiologists had any role in these areas, 100% basically did non-operating room anesthesia, intensive care in these countries. Intensive care was done by anesthesia in 90% of the scenarios. 90% worked in pre-op assessment clinics. Pain medicine was practiced by anesthesiologists in 90% of the cases. Emergency medicine, interesting, 50% had anesthesiologists involved in those countries, and palliative care only in 40% of those countries. If there were some incentives for out-of-OR activities, the concerns about these things were significant in these areas. And what about the hurdles of doing these things? Basically, remuneration. There was difficulty in having remuneration for these activities outside the OR, which basically hindered the ability of anesthesiologists to participate. So overall, it is interesting that among the people that we surveyed, there was a significant interest of colleagues participating in out-of-OR activities. Next will be Dr. Karim Khalid. She's a consultant at the Mohas Hospital in Tanzania. She is a member of the board of directors of the Essential Emergency Critical Care team group. And she was unable to be present here, so she will deliver her lecture that was pre-recorded.
And critical care doctor based in Dar es Salaam, Tanzania, and I'm so happy to have been invited to speak at this event, and sorry that I was not able to join you physically, but technology has allowed us to do this even at a distance. I will be presenting on ensuring patient safety through essential emergency and critical care in this session together with my colleagues from WFSA Intensive and Critical Care Medicine Committee. And I'll start with sharing my slides so that you can all be on the same page together. So I have no conflict of interest related to this presentation. So I'll just start with presenting to you a few cases of patients that we might all have encountered in our daily work in different situations. So one of them is Maria, who was presented to hospital semi-conscious who had seizures, and she was diagnosed to be preeclamptic, and an emergency C-section is done, and a healthy baby is delivered. And she's sent to the ward. But early in the morning, you go back to your ward and find that your patient has passed away. And then the second patient is John, who had a road traffic accident. He went to a state-of-the-art hospital, arrived at the facility covered in blood, and he was diagnosed as having polytrauma. The CT scan is done, and surgery is done, and then he's sent to the ward. But the next day you go to visit your patient, and unfortunately you're told the patient has passed away. These are common stories that we hear of patients in our daily practices in different parts of the world, whereby patients deteriorate in the wards and they become critically ill. When we talk about critical illness here, we mean that any kind of organ dysfunction with the potential of reversibility if care is provided. So these patients, as you can see, received state-of-the-art obstetric or trauma care. So maybe they did not die because they had obstetric complications or trauma complications, but they probably deteriorated overnight and became critically ill, and they were not recognized in the ward, and the most fundamental care of critical illness was not provided to these patients. So does this matter? Why does the patient safety matter? It matters a lot because we know that globally, we don't have very good numbers of how common patients become critically ill, but we know that at least every year, 7 million children in lower and middle income countries require oxygen for pneumonia alone, and 45 million adults become critically ill every year. And around 2 of these patients in our wards are critically ill. And they have a really high mortality if care is not being provided. And you can see that from the diagram that I'm presenting here. Critical illness cuts across all specialties at any part of a facility, any kind of patients that are presenting to us, be it surgery, be it maternal conditions or infectious diseases. And they have a really high mortality of around 18 to 28%. So when we speak about ensuring the safety through EECC, it's because EECC provides a structural way to bridge this safety gap. And patients' safety starts with recognizing these patients where they are and managing their critical illness where they are immediately, and also escalating their care to higher intensive care or higher type of care when needed. But we know that majority might just benefit from this very basic care that can be provided where they are in the wards, and their lives could be saved. So where are these critically ill patients that they're talking about? We see that from studies that have been done globally in different parts of the world that these patients are actually in all areas of our facilities. There's this tendency to think that critically ill patients are found in ICUs, but we've seen that in many different studies that most of our critically ill patients are actually found in general wards. That is around 90% of these patients. And the care that these patients would need mostly to save their lives is actually essential emergency and critical care, which is defined as the care that all critical ill patients should receive in all health facilities in the world, which is the most fundamental care for critical illness. It is effective and is low cost and is feasible in any healthcare facility. We've been talking about the emergency critical operative care resolution, and ECC actually forms the basis of this or the foundation of this care that the foundation of the emergency critical and operative care. And how about looking at the cost and complexity of critical care? When we're speaking of this most basic care, which actually consists of airway management, oxygen, things like giving fluids and triaging and monitoring of patients, we see that it cuts across a large population in our facilities, from the emergency unit, operating theaters, in our ICUs, in our wards, and most patients who get a derangement of their vitals and become critically ill would benefit from just this baseline care if they are recognized early and this care is provided. And some of these patients might need a higher level of care, which we term as intermediate emergency care, whereby you will use things like CPAP and vasopressors, and a few would need advanced emergency care, where we will now have mechanical ventilation, ECMOs, renal replacement therapy. But this, as we go higher, we have to realize that also the cost becomes much higher. We've done Delphi, we have done modeling studies to look at the cost and cost effectiveness of ECC, and it costs us about $14 per daily averted. So this concept came out, the ECC was conceptualized, and then there had to be a consensus on what the contents of ECC would be. And there was a Delphi consensus that was done with 269 clinical experts participating in it, most from LMICs and many from middle and high income countries, with expertise from cutting across all specialties, from emergency, intensive care, anesthesia, medicine, and obstetric care. And all cadres were also involved. And from this, we came up with 40 clinical processes and 66 readiness requirements that are needed to provide ECC. And these are very basic things like triaging all patients, giving them oxygen and IV fluids and the like. Why should we incorporate ECC to ensure the safety of our patients? There are so many advantages of this. It improves the care and outcome of critically ill patients everywhere, including the primary health care and even in our general wards, even going back to our emergencies and our ICUs and our theaters. It's low cost and cost effective. As I just mentioned, it costs around $40 per daily, and it covers a really huge quality gap. And it also ensures equity. No patient group is left behind. It cuts across all ages, and it's time critical care time critical care needs of patients are all prioritized. It is designed for task sharing. The whole team can manage critical ill patients. So we know in many settings, we don't have the doctor available at all times in the wards. And this approach enables whoever is in the facility or in that ward at any moment, be it a nurse, be it a junior doctor or a senior doctor, to be able to provide this care. It also increases our preparedness for public health emergencies. We don't know when this could happen, but if we are ready in our facilities to provide this foundational care, it will be easier for us to escalate it to higher levels of care. And there's a lot of investment on ICUs, on oxygen that have been done globally. And to maximize these efforts, by ensuring that ECC is being provided or it's done properly, ensuring that we enable the people who are providing this care with knowledge, with skills, with resources to use the oxygen that we are increasing in the world, then it will have high impacts on our patient population. So we did also a study in Africa to see how big is the burden of critical illness in our facilities, and this was done across. It was done across 22 countries in Africa. And what we saw in this was 1 out of 8 patients are critically ill in our wards, in our hospitals. And 70% of these patients are in the wards. Once again, this was proved. And 56% of these patients are not receiving this most basic care that I just described in the wards. And 21% of these patients were dying within 7 days. So it's a huge gap that needs to be covered with just providing the basics and making sure that our patients are safely treated and go back home from our facilities. This is not only an African problem or an LMIC problem. I said that was done in Sweden, that is yet to be published, so that also they had almost a 48% unmet need for ECC. So patients were not, 48% of the patients lying in their wards were not also receiving ECC. So in Tanzania, after showing this gap, the government decided to come up with an approach to ensure that ECC is provided to all patients who become critically ill in their facilities. And this is to ensure that we have a good coverage or good population impact in the country. And to do this, the governments both of the mainland and islands of Zanzibar decided to come up with a national strategic plan to implement ECC, and they started with integrating it into the primary healthcare facilities in 5 regions of the mainland and in Zanzibar as the 6th part of the work. And to be able to do this, we had to understand what the problems are that are making this most basic care not being provided. We know that it could be knowledge, it could be other things. So we did a lot of in-depth mixed method assessments and find out where the problems are. This whole program consists of more than 30 facilities, but we assessed all of them and went in depth into 24 facilities and found that there are gaps in knowledge and skills. There's also insufficient use of staff time. A lot of time is used to move around, look for resources here and there. And you know that when patients become critical, they need care immediately. Have no time to move around and look for resources. And also they were using a lot of time for documentation and not taking care of patients. And there was also poor availability and distribution of resources. So you might be in a ward, but the pulse oximeter is locked. You have to find the nurse in charge to open it for you. You might be in a ward where the oxygen is in another ward or in another area. You have to go and look for it, or fluids and other drugs are in the pharmacy. You have to find them. So you can see that things are not well placed to provide this care. They need to be around the healthcare provider to assist her use her time effectively and provide the care timely. Oxygen was also not in place or not in use in some of these facilities. And there was also much misperceived role of lower level facilities whereby they thought these critically ill patients need to be referred immediately and they will not even provide them with this most basic care. And there was also service organization barriers whereby, resources, the infrastructure of the facility is not really conducive to providing care to these critically patients who may become critical, and the motivation of the excuse me, of the healthcare providers was also low in taking care of these patients, all because of this, you have to run around, and there was also this feeling that if a patient becomes critical, then I'm not able to provide the care that they need, so they're not motivated to provide care to them. And there was also a lot of emphasis on advanced care without ECC. So they advanced care like ECC, ICU care is seen as to be more like attractive. People want to do that, but that for me to be able, as an anesthesia provider, an intensive care provider, I need to be able to have my patients well taken care in the wards, pre and post ICU or pre and post surgery, to be able to have a higher impact of the work that I'm doing. And there was also a lot of emphasis on vertical programs determined by managers, determining the managers' priorities. Things like HIV programs, malaria programs, they were seen as, there were a lot of emphasis put on those, because there's an assumption that this basic care is actually being provided, but we've seen from the study that you've done, the surveys, that this care is also missing in our facilities. So we sat down with the providers and the government and the technical people to come up with a way to implement this ECC into our healthcare facilities using the implementation research and implementation science. And we used the COM-B model, focusing on capability, opportunity, and motivation to change the behavior of our providers so that they can provide this care. And we came up with 6 aspects of it, or 6 interventions, which one was training the healthcare providers, but also capacitating the leaders in workshops, whereby we realized that just training people will not be sufficient. You need to also involve their leaders to understand why this care is important, that they can prioritize even their procurement methods, ensure resources are available, and support the healthcare providers who are actually providing the care. And we also introduced tools to promote ECC provision in the facilities, and we also increased equipment and supplies for ECC provision. And this was not done by providing these resources, but also working with the leaders to prioritize these resources and ensure that they're actually in place, because they're not really missing in the systems, but they're just displaced and they're not ordered in time. And then we also designated focal persons in each of the facilities. These are people who are motivated and could motivate others to move forward this provision of ECC. We also came up with a way to motivate them by capturing their data. They will send us some information on how they're performing in terms of how many the vitals of the critical patients, what care they're providing, and then we will process the data and send it back to them. And they would know what the burden is in their facilities and what is lacking, where they're lacking, be it knowledge, be it the resources, and changes can be made in time or over time to ensure this care is provided to the patients. And we did this in 3 types of packages, whereby in one we emphasize healthcare worker training, one we emphasize on empowering the managers, and one where we had full ECC training and provision in one, which we call the ECC center, which worked as a hub with spokes around it. And we wanted to see which bundle would work best. And we were able to, with this, to train all the healthcare workers that were aimed to be trained, who were around 1,773. Around 200 leaders were participated in the healthcare, in the leadership workshops, and 140 focal persons were trained, and tools are distributed to all these facilities. And we had different methods, like the vital sign sensors, which I talked about, where they would send us data on their vitals, and we would work on that and give them feedback. We have been having webinars with them, the leaders, the healthcare providers, to share knowledge, and also to encourage each other on the best way to move forward. We have WhatsApp groups, and also where the people will send cases. As you can see here, there's a child, they were not doing intraosseous cannulation, but when they did it, they shared with the other groups, and everyone was motivated to continue doing this. And things like the incorporating ECC in the ward rounds and talking about critical ill patients in each of the ward rounds, doing handover of all the resources to ensure that every shift has all the resources, or also some of the things that were done. This is the vital sign directed therapy protocol that was seen to be one of, so far as we're doing this, is the 4th month into the program, and we can see that people are really happy with this tool because they can say it helps them identify that the patient is actually critical, and it also empowers them to provide care immediately. What we were seeing before, that healthcare providers were becoming paralyzed when they have these patients because they didn't know what to do and they didn't have the resources ready. Now that they have the resources with them and they have a tool to help them guide to do what they need to do, helps them to take care of these patients when their conditions become critical. And we've seen with the trends, with the knowledge sharing and caption that we're doing, the provision of this care has gone up much higher in the last 3 to 4 months, and it has stayed a little kind of the same with around 80% in June, July, August, and even in September. And we continue following it up to see if this is sustained, and also where there are gaps or how we can do better in the future. And outcomes have been good. We have anecdotal outcomes. We have done an in-depth assessment again with mixed methods, interviews, qualitative and quantitative work to see where we are right now. But you've seen these anecdotal reports like this one from one of the regional managers saying there has been a significant reduction in maternal deaths, and since the ECC implementation began in June, and there has been a marked decrease in the need of referrals, and we have only had 1 maternal death in the district hospital and none in the whole of our district council. This has never happened in history, which is really a good, encouraging report from the leaders. And we have seen also they have been able to utilize their own funds to train further more people in their regions, and also procure resources for their facilities, which has really been very encouraging to see, because they have seen the benefits. The patients' outcomes are becoming better, they're working better, and people are really motivated. We're yet to process the data and to see the evidence as it comes out, but there are quite good results from what we are hearing and what you're seeing in the data sharing. So this is a success story for baby Lillian, who was referred to, who went to in a health facility in rural Tanzania, and when she was born, she was struggling to breathe, and a nurse who was training ECC quickly assessed her and found that she was in respiratory distress. Her breathing was dangerously fast. She did a pulse oximetry and it showed that the baby was hypoxic. She then put an nasal prong on the baby, and her breathing became better.
Sorry,
She
in
used
the
Esperanto that
essence
was
of
also
time,
provided
I'm
to
gonna
them to call
speed it
senior
up
help
a
after
little
that,
bit
and
to the
baby
conclusion,
survived.
okay? Oh,
So thank you
perfect.
very much. So I really believe if we can incorporate ECC in our daily practice, from the way we are seeing our patients in theaters, in emergency units, in ICUs, and ensuring that in the ward this care is being provided, then the survival rates and the safety of our patients will increase in time, and both us healthcare providers will have better satisfaction with our work, and our patients will also survive this outcome. Thank you very much for the opportunity.
I'm going to be speaking about initial resuscitation in septic shock. All you need to know. I bring you greetings from the Tata Memorial Hospital in Mumbai, where I work in India. My disclosures: I'm the chair of the Critical Care Committee of the WFSA. I'm also a board member of the Global Sepsis Alliance and the Asia Pacific Sepsis Alliance. And I'm a member of the Surviving Sepsis Campaign Research Committee, and also the next iteration of the Surviving Sepsis Campaign guidelines. Now, the initial resuscitation I'm going to be talking to you is, of course, from the Surviving Sepsis Campaign Guidelines of 2021, which was published in Intensive Care Medicine and also Critical Care Medicine. Now, I'm only going to restrict myself to the initial resuscitation. And in the initial resuscitation, this is just a summary of the recommendations. And as you can see, the treatment begins immediately. That's a best practice statement. You don't need a randomized controlled trial to tell you that. At least 30 ml of crystalloid should be given within the first 3 hours, and this has been downgraded from a strong recommendation to a weak one. And then we talk about dynamic measures to assess fluid responsiveness subsequently, and also guiding the resuscitation by decrease in the lactate levels when they're elevated, and also a new recommendation for using capillary refill time to guide resuscitation as an adjunct. And as you can see, most of these are weak or with low quality of evidence, and I'll talk about each of them in a bit. So one of the most controversial recommendations is the 30 ml of fluid, crystalloid, given over 3 hours. And, we don't give fluid and then come back after 3 hours. 3 hours is a really long time. And a 30 ml, this recommendation is based on one retrospective trial, and it's one of the most debated in the critical care community. Now, if you look, as soon after the Surviving Sepsis Campaign guidelines were published, along with Professor Jean-Louis Vincent and a group of us, we came up with this, we wrote this article on how you could equilibrate the Surviving Sepsis Campaign guidelines with individualized care, where you could be within the framework of the Surviving Sepsis Campaign guidelines, and yet you could individualize care. And I can tell you how you can do this for the 30 ml per kg. So we came up with about 20 recommendations on how you could individualize, and in the interest of time, I won't tell you about this, but I'll definitely talk up to you about the 30 mils per kg. Now, giving 30 mils per kg to a young fellow with a patient with no comorbidities is not the same as giving it to an elderly gentleman with renal dysfunction and cardiac dysfunction. I'm sure you all appreciate that, and you can't have a one-size-fits-all approach. I like this publication very much. Excuse me, and it talks about how you could individualize this fluid resuscitation in these patients at 30 mL per kg. So we have a period of 3 hours, so perhaps you can start with a lower volume of 10 ml per kg initially in the first 30 to 60 minutes, and then you look at the response, okay? And especially if there's evidence of fluid loss, abdominal sepsis, fever, and signs of tissue perfusion continue, you probably want to give more fluid. On the other hand, if the patient starts getting tachypneic and is desaturating, you'll probably be cautious about giving more fluids. And subsequently, if the shock persists, of course, you can assess fluid responsiveness before giving more fluid. So someone might need 50 mils per kg. On the other hand, you may stop at 10 mils per kg for some patients, and this is how you can individualize the initial fluid resuscitation. The Surviving Sepsis Campaign guidelines talks about dynamic measures to assess fluid responsiveness, and they talk about suggest using this to guide fluid resuscitation over physical examination and using static parameters like CVP and pulmonary artery occlusion pressure. And what are the parameters they talk about? They talk about passive leg raising, looking at pulse pressure variation, stroke volume variation, etc. So let's talk about passive leg raising. I'm not sure how many of you do it, but passive leg raising is a simple test that you could do at the bedside, and it's really important that you move the bed and not the patient, because you could have tachycardia, which could increase the cardiac output. And how do you interpret this? You need an increase in cardiac output by more than 10%. That's the cutoff value, and this will tell you whether the patient is a fluid responder or not. But again, it needs continuous real-time cardiac output monitoring, so you need cardiac output monitoring. You could even do this measuring VTI using echocardiography. Other measures like pulse pressure variation and stroke volume variation, and these are real time. And when you look at pulse pressure variation, you don't need a cardiac output monitor. All you need is an arterial line. And you get these kind of values on the monitor. And if your value is above these cutoffs, then this patient is a fluid responder, and with a good specificity and sensitivity. And it's widely tested. And there are 3 meta-analyses that show a very good reliability of pulse pressure variation and stroke volume variation. However, these studies that are recommended, these tests are not without limitations, and there are many situations that cause false positive and false negative, and one of the most common is the use of low tidal volume. And most of these studies are done with tidal volumes that are more than 8 ml per kg ideal body weight, and we know that today not only in the intensive care unit, but even in the operating room, we're more gentle on the lung, and we use tidal volumes less than 8 ml per kg. So excellent tests, work very well, but a tidal volume more than 8 ml per kg. And what are you going to do if your tidal volume that you're using is less than 8 ml per kg? These tests are not reliable. So in our unit, we developed a new test called the Tidal Volume Challenge, which we publish in Critical Care Medicine. And we hypothesized that, okay, this works very well at 6 ml per kg, but doesn't work well at 8 ml per kg. So at 6 ml per kg, sorry. So why don't we transiently increase the tidal volume from 6 ml per kg to 8 ml per kg, and then look at the pulse pressure variation and the stroke volume variation? And if you see, we were quite naive actually. At 6 ml per kg, of course, it did not work. But at 8 ml per kg, if you see, the area under the curve was much better. But what was even better than the value at 8 ml per kg was the delta PPV and the delta SVV. That is the difference between the pulse pressure variation or stroke volume variation at 6 ml per kg and 8 ml per kg. And we got cutoff values of 3.5 and 2.5. And I'll show you how easy it is to do this test to overcome the limitations with the low tidal volume. So here you can see, and this is your ventilator, and here you can see the patient is ventilated with idle body weight is 45, and 6 ml per kg is the tidal volume used. And here you can see the pulse pressure variation. Now, how you give a tidal volume challenge is you increase the tidal volume from 6 ml per kg to 8 ml per kg, so that becomes 360, and then you observe the pulse pressure variation. Now, in a responder, you will see the pulse pressure variation increasing very rapidly, and of course, we don't do this for more than a minute because we want to get the pulse pressure back to 6 ml per kg. We don't want to keep the patient at a higher tidal volume, and you can see that we started with 8, it went to 10, from 10 it's moved to 13. And after 1 minute, we bring the tidal volume back, as I mentioned, to 6 ml. So you can see the pulse pressure variation has become 15. And I'm going to reduce the tidal volume back from 360 to 270, which was the basal value. And it's very interesting because when you bring the tidal volume back to 6 ml per kg, the pulse pressure variation also goes back to where, and those of you who've used pulse pressure variation, it's a very sensitive indicator. And there's a very easy test you could do at a bedside when you're using pulse pressure variation, because all you need is an arterial line that you would already have in a patient in shock. This was a proof of concept study we did in our unit. It became very popular globally, and now there's a meta-analysis of this, several studies done using the tidal volume challenge that has shown good reliability of this test. And therefore, when you use pulse pressure variation and stroke volume variation in patients with low tidal volume, the tidal volume challenge can be used to overcome these limitations. So these are the commonly used tests to assess fluid responsiveness. Most of them are well demonstrated, and if you're using pulse pressure variation, stroke volume variation, tidal volume challenge, or even ultrasound collapsibility, it's reliable even without using cardiac output monitoring. The other recommendations about the use of serum lactate and capillary refill time. So if your lactates are high, and usually the cutoff that you take is 2 millimoles per liter, then they suggest that you should decrease the serum lactate in patients with elevated lactate values, and be very cautious about interpreting the lactate, and I'll talk to you about it in a bit. And they also talk about use of capillary refill time to guide the fluid resuscitation, of course, as an adjunct to other measures for assessing tissue perfusion. So when we talk about the high lactate, the interpretation is really important. Every high lactate doesn't mean that it is tissue hypoxia. So there may be other reasons why your lactates are elevated. One could be increased production, and could also be decreased clearance, for instance, when there's liver dysfunction and other conditions. And you could also have aerobic metabolism. For example, if in patients in whom you use adrenaline, there could be accelerated glycolysis, because of which the adrenaline lactate production is increased, and this is not because there is tissue hypoxia. So you have to be a little careful about interpreting lactate. Don't look at lactate in isolation, but along with other parameters, looking at the tissue perfusion. And capillary refill time, this is something that's really good, especially in resource-limited setting. And this suggestion comes from the Andromeda study, which compared the tissue perfusion using the capillary refill time versus the lactate levels, looking at the lactate clearance. And of course, there was no difference in the 28-day mortality, which was a primary outcome. But what was encouraging is that at day 3, the capillary refill time was significantly, the organ failure was significantly less, and also the SOFA scores by the day 3. And therefore, this could be used in conjunction, and it's easy to do. The only problem is it's not really standardized, so that really needs to be done, but otherwise a good and easy test to do at the bedside. Well, we've just talked about fluids with initial resuscitation, but what about vasoactive medications? And this is also important, and the vasopressor of choice is, of course, norepinephrine, and the target MAP, a lot of people talk about 65, but remember 65 is the initial target for resuscitation. Subsequently, you should be individualizing. But what's really important is it's not about giving fluid first and then talking about giving vasoactive drugs. There are certain situations where you might have to give the vasopressors, co-administer the vasopressors along with the fluids. And which are these situations? When you have life-threatening hypotension, right? You don't have enough time to give fluid and then start vasopressors, so you may need to co-administer both of them. When there's a contraindication to give fluid, you can actually start the vasopressors, and this can limit the volume of fluid you give. And the third very important indication is when you have a low diastolic pressure. So even if you have the same MAP, the diastolic pressure may be lower. And when you have a low diastolic pressure, this is a very vasodilated patient, and that's the patient in whom I would start norepinephrine much earlier. So it's not like only give fluid first and then start vasopressors. There are indications when you might have to co-administer the vasopressor. Now, what about resource-limited settings? And as part of the Asia-Pacific Sepsis Alliance, we did this global Delphi looking at sepsis management in low-resource settings and how we could give guidance in these regions. For example, if you don't have lactates, does that mean I can't make a diagnosis? Does that mean I cannot manage a patient with septic shock? And we published this Global Delphi in intensive care medicine, and we took experts from across the globe, and 70% were from low middle income countries and 30% were from high resource countries, and we came up with very nice clinical practice statements for management of sepsis in low resource settings. In the interest of time, I won't talk to you, I won't discuss this, but I'll definitely talk about that for hemodynamic monitoring. And we talk about clinical parameters such as capillary refill time, urine output, etc., to guide resuscitation. And also when facilities when you don't have advanced hemodynamic monitoring, you could guide your therapy using simple tools like pulse pressure variation, which requires an arterial line, tidal volume challenge, or even your passive leg raising or ultrasonography if it's available. And other recommendations, I won't talk about that, but epinephrine, not only initially, if vasopressors like norepinephrine are not available or vasopressin is not available, you could use epinephrine, but also continued, not only started from a peripheral line, but also continued if you don't have the expertise or availability of a central line or the expertise to use it. So the key takeaway message is that time is tissue, so you need to start the resuscitation immediately when you have a patient in septic shock. And fluids first, but not forever. You need to assess fluid responsiveness because giving excess fluid is also harmful for the patient, especially when you have a positive fluid balance after 5 to 7 days. And norepinephrine can be started early, when the hypotension persists or in specific situations which I mentioned to you. Avoid overfluid resuscitation and decrease the secretin lactates in patients with elevated lactate levels and try to bring them down. But again, interpret the lactates very cautiously. And capillary refill time is a promising test that we could use. We have the Andromeda Shock 2 study that will probably show promising results, will be published very soon by end of October. So we could use this to guide resuscitation in conjunction with the other measures for tissue perfusion. So watch this space. Coming up soon is the next iteration of the Surviving Sepsis Campaign guidelines, which will be published in 2026. And we also have another guidance on gaps in guidance for sepsis management in low resource settings that will be coming very soon. And I'll leave you with our recent publication on the minutes bundle. And this is a very nice way by which in the first 30 minutes of an undifferentiated shock, you could actually manage these patients. And the minute starts for you maintain the ABCs, you infuse fluids, vasopressors, you investigate the patient, and of course a role for ultrasound to diagnose the type of shock, treat the etiology, and stabilize the patient. And again, I'm making a pitch for all of you to attend the World Congress of Anesthesia in Marrakesh in Morocco. And with that, I thank you very much for your attention. I'm happy to take questions.
Do you have any questions for our speakers? Please. Why do you want to have the mic? It's like that. Any questions?
So I work in a pre-op clinic where our whole practice is geriatric high-risk patients coming in for complex surgeries. And so we often are doing appropriateness evaluations for people who we're helping with shared decision-making. And so some of these patients are DNR, and that's their outpatient status. And, as we know, that doesn't apply to the inpatient care. And part of our job is to have those conversations. And a lot of patients are really not wanting chest compressions, in the whole setting. Like, I let them know you're going to be intubated for this. So of course that doesn't apply. And you're going to need, we need to be able to give you pressors. That doesn't apply. And so sometimes they go to the OR with a specific request to avoid chest compressions. And I'm sort of thinking, based on your talk that you started with, that, that should be something that we should kind of push hard to move people away from, at least in the intra-op setting where, that is highly successful in the right indication. It seems like maybe we need to push a little harder, talking people out of that. Would you comment on that?
Yeah, thank you very much for this question. I mean, it's always a thing that you need to discuss with the patients up front, if possible. I mean, the cardiac arrest in the OR is not so very often, fortunately. But if it is occurring, it is in many cases anything that is related to the surgical procedure, something went wrong, you have a severe bleeding, you have a tension pneumothorax, you have pericardial tamponade, or something like this. So you have a iatrogenic reason for the cardiac arrest. And in this case, I think it's a little bit different if you explain it to the patient upfront. I mean, many patients don't want to be for days ventilated on the ICU or something like this, what they have seen in television. But if you tell them if there is a complication in the OR that can be handled, in that case, would you also not have chest compressions? And I'm sure that most of the patients will then say, no, if it is due to some issues during surgery, you should help me. That's I hope you are happy with this answer.
Yeah, I think it was ringing home to me because for whatever reason, that's a particular hang up for a lot of people. They're willing to relinquish everything but the chest compressions. And I don't know if that's because of the kinds of conversations they're having in the outpatient world about, you should say no to that when you're sort of at this stage. But yeah, thank you.
I just want to add a comment. I mean, just listening to Bernd's presentation, and you see the outcomes are so good, and you have all the resources and everything. I mean, you really have to rethink that all CPR, chest compression is not the same. So I'm sure once you counsel the patient and they say no for CPR, and you tell them, look, the outcomes are good, and things like that, I'm sure they would probably change their mind if we give them the information. But what often happens is we don't give them that information.
And I think there's also another reason. So if a complication is iatrogenic, so if the surgeon or the anesthesiologists are the source of this complication, it may also protect the surgeon or the anesthesiologist if you then are doing successful resuscitation. I mean, and I think it's also the right of the anesthesiologist or the surgeon to be helped in such a case and
To fix it.
Yes, absolutely.
Well, it's been an interesting transition because I think we used to make patients, we'd sort of force the issue to say you should you should suspend the DNR when you're in the operating room. And so there's been this negotiation that goes on with, trying to have that conversation pretty carefully. And so I think this is, just talking about these outcomes just makes me think we got to not tie people's hands in the operating room, and we should kind of, to some degree, the in-OR practice of suspension of DNR is still probably totally appropriate. And if you have the conversation in the right way,
But probably the ideal would be to talk with the patient beforehand. And the DNR, what ifs in the OR. Probably, in our hospitals, would have a couple of patients like those, and we would ask the patient and the family, so that they together would think about it, because what Bernd said, it is something which we are speeding the demise of the patient, and it's just an accident. It's not planned that we will just simply, euthanize the patient.
And you have also seen in one of my slides that a lot of cardiac arrest in the OR occur at the age of below 3 years. So, and do not resuscitate a child. I don't know whether this is really...
No, that doesn't come up too often.
Parent would not say do not resuscitate a child. It happens more in the other extreme when they're much older, yeah.
I have a question, Sheila. When talking about the pulse pressure variation, this is a concept that has been described by the French since 1999, actually. 1999, the Tavernier published this first paper showing the impact of this. Unfortunately, it's not still popular around the world to people to use PPV.
Actually, it's most
do you use it in India? Is it popular?
Yeah, it is. Actually, it's one of the most widely used, and now with ultrasonography. And if you see, it's most reliable in the operating room. We use it a lot in the intensive care unit, but because muscle relaxants are used and the patient is paralyzed in the operating room, it's actually most reliable. And what people don't realize is pulse pressure variation does not need continuous cardiac output monitoring to assess fluid responsiveness. So if you're using CVP or PAOP, which are static parameters of fluid responsiveness, and they are not reliable. I'm not saying CVP is useless, but it doesn't help you predict fluid responsiveness. And a lot of people are still using CVP. And you have this dynamic parameter that's so useful that can, you can get with just an arterial line, and you would have one in a patient with septic shock. It's really useful to use even in a resource-limited settings.
Actually, I taught cardiac physiology for a long period of time. So since the mid-90s, I've been against using static parameters. Yeah. And actually, the first papers, clinical papers came in the late 70s about the pulse pressure variation. And actually, I like the monitor that automatically showed the PPV without, because nowadays we have all these new devices, flow track, and all this stuff that will provide this number. But you can actually do it. I found out in that the Philips monitors have these software included in their menus for 20 years or so.
So it's very interesting you say this, because for 10 years I did not know that if you transduce an arterial line, you could get PPV. And I went to I was listening to a French person speaking about PPV, and I went back and I said, how do we get PPV on this monitor? He said, oh, you want it? The guy from the industry, and he just clicked a button and I had PPV. And I said, what? For 10 years, I wasn't using this. So people really don't know that if you can transduce an arterial line, and not Philips, on any monitor that can transduce an arterial line, you can get pulse pressure variation. And you have this very reliable parameter, and probably that's why the Surviving Sepsis Campaign guidelines recommend that you use it. And if you use it in conjunction with tidal volume challenge, when you use a low tidal volume, well, you have a very reliable parameter in your hands.
We use it. I've been promoting this since late 1999. And it became a standard in our hospital, and it has been, in Colombia, it's become very popular because it's very simple and it's free. You don't have to buy any transducer or whatever. So it's really, really, really simple. Okay, thank you very much for attending this WFSA session, and you're invited to come into our World Congress of Anesthesia in Morocco and Marrakech in April next year.
April 2026.
Okay. Thank you.